Well, hello and welcome everyone. Thanks for joining us at our Facebook Live event today, Looking After Little Lungs, a partnership between the Centre for Research Excellence in Newborn Medicine and the Life's Little Treasures Foundation. My name's Brett Manley. I'm a consultant neonatologist at the Royal Women's Hospital. So my job is to look after unwell and premature little babies in our neonatal intensive care unit for as long as they're in our hospital. But I also look after families before babies are born in order to prepare them for the birth of their child, and also up until they're about 2 years of age. We like to follow our babies at least for a year or two to see how they're developing. And with me today is my friend and mentor, Professor Lex Doyle. Lex, could you introduce yourself?
Thanks, Brett. Welcome, everyone. My name's Lex Doyle. I'm a neonatal paediatrician who started to look after babies back in 1975 for the first time at the old Women's Hospital in Carlton. At that time, we were just starting to use ventilators to help babies to breathe, and prior to ventilators, most little babies with big breathing problems just died from exhaustion after a day or two. There wasn't much we could do about it. But the machines came along. We didn't really know what we were doing with them to start with, but gradually people developed the skills to help keep more and more babies alive. There are lots of other changes going on around that time, including the introduction of corticosteroids given to mothers to help improve lung maturation, and they made a big difference. And then later on, we were able to use a medicine called surfactant, which Brett will tell us about shortly. So over the more than 40 years I've been looking after little babies, I've seen big changes in terms of survival and long-term outcome. I stopped working in the nursery about 12 years ago, mainly because I was too busy with research, and what my research has focused on has been looking at the long-term outcomes for those little babies who survive, and that includes following them through childhood and now into adulthood, and that's been very rewarding, and I'll tell you a little bit about some of the results from that research shortly.
Well, thanks, Lex. We're very lucky to have you here today to tell us about long-term follow-up and development of our preterm babies. So as I mentioned, today's session is a partnership between the Centre for Research Excellence in Newborn Medicine and Life's Little Treasures Foundation. It's the first of what we hope will be many such events that we're calling the Prematurity Roadmap, information and question and answer sessions for parents of premature infants. And today we're talking about lung health, particularly of preterm infants, both whilst they're in the nursery, the sorts of problems they might have and how we might treat those, and then just as importantly or more importantly, following them up after they go home from hospital and the sorts of things parents might need to know about the health of their preterm babies after leaving the hospital. As we talk today, you'll have the opportunity to post your questions on the Facebook page, and we really encourage you to do so. At the end of our presentation, Lex and I will try and answer as many of those as we can. And if there's any that we don't get to, we'll continue to try and answer those over the coming days and weeks. So please, if you think of something after today's session or you're watching it later on the net, then please send those comments through and we'll do our best to respond. So we're going to start the session today with a few slides. Firstly, I'm going to talk about what happens with little babies in hospital, and then Lex will take over and talk about what happens after they go home. So firstly, we're going to talk about what goes on in the neonatal intensive care unit. And we spend a lot of our time in the NICU looking after babies with what we call respiratory distress, which really just means breathing problems. And how we tell if a baby has respiratory distress is to look at them, their physiological signs, and to examine them. The first thing we look at is a baby breathing too fast? And newborn babies breathe faster than children or adults do. When they're first born, they might breathe at 40 or 50 or 60 breaths per minute, but anything more than 60 breaths per minute, we think that might be too fast. We also look at them and try and tell whether they're working harder with their breathing, and the sorts of things we look at are they having to make extra noise when they're breathing? Are they sucking in under their ribs or between their ribs that might show that they're needing to use more of their muscles to breathe? Noisy breathing can also be a sign of respiratory distress, either with a problem in the upper airway or down in the lungs. And of course, low oxygen levels or turning blue that we call cyanosis is a sign that not enough oxygen is getting around the baby's body. And there are many causes of respiratory distress in infants that we look after in the NICU, some of which are listed here. That includes an acid buildup around the time of birth, caused by a lack of oxygen or blood supply, that their temperature is too low or too high, and we have to be very careful with monitoring and maintaining newborn babies' temperature in the first hours after birth. They might have an infection, and we commonly treat babies with breathing problems with antibiotics. There could be fluid in the lungs, particularly after a caesarean section, but sometimes in babies who haven't had a caesarean section. There could be a problem called meconium aspiration, where actually the newborn baby's got into trouble before it's born and passed a bowel action and then inhaled some of that into the lungs. A pneumothorax is an air leak from the lung, commonly called a punctured lung, and we see that not uncommonly. And of course, there are many congenital problems such as heart problems or lung problems that can cause breathing issues. This is a chest x-ray that those of you who've had babies in the NICU will be very familiar with, and we commonly use x-rays to monitor how babies' lungs are inflated and also to try and make a diagnosis of why they're having breathing troubles. I've labelled here the lungs on the outside on both sides, which are the darker areas, and these are quite healthy looking lungs actually, nice and dark. In the middle, the white blob there is the heart, and the darker white areas up the middle are the spine. In fact, this baby has had some trouble despite having lungs that look quite healthy, because I can see a breathing tube in place there, which means that this baby's been receiving mechanical ventilation in the neonatal unit. And here are some other chest x-rays as an example of how different they can look when babies are having trouble. On the left in the top left corner there is the x-ray with the normal lungs, and then down below on the left-hand side you can see lungs that are not looking as black. They look white and quite dirty, and that's a baby who's had trouble with meconium aspiration. And then on the right-hand side, the lung there looks even darker on one side than the other, and that's actually too much air around the lungs, and that's a pneumothorax or a punctured lung that needs treating. But when we talk about preterm babies, we're talking about a very common breathing problem called respiratory distress syndrome, or RDS. And this is a breathing problem that we spend a lot of our time treating in the neonatal intensive care units, and that's mainly because preterm birth is now becoming so common. In different countries, between 8 to 12% of all births are now preterm, before 37 weeks gestation. And when we're talking about the neonatal intensive care unit, we're often looking after babies born even much earlier than that, sometimes very preterm, before 32 weeks of gestation, or extremely preterm, before 28 weeks of gestation. And the earlier babies are born, the more breathing problems they tend to have. And this is mainly due to this respiratory distress syndrome, which is a combination of having immature lungs and also a lack of a very important substance called surfactant in the lungs that we all have. And the job of surfactant is to coat the smallest airways and stop them collapsing. So if there's a lack of surfactant in the lungs, the very smallest airways that are important for getting oxygen in and carbon dioxide out are not inflated and therefore not working as they need to be. And some infants can cope without enough surfactant, and others can't. And this is just a diagram that Lex made up showing how surfactant can work. And this is supposed to be a small airway here with in white, and the surfactant molecules sort themselves out around the wall of the airway and push back on each other and keep that little airway open. And we know that the more premature you're born, the more likely as a preterm baby you are to have breathing problems. And also, boys tend to have more trouble than girls. And conversely, protective factors include being more mature, and the more mature that you're born, the less likely you are to have breathing troubles from respiratory distress syndrome. And also importantly, we know that antenatal corticosteroids, these are the steroids injections given to mothers before preterm birth if there's time, are very protective and really improve babies' chances of surviving and reduce the risk of having bad lung disease after they're born. So antenatal corticosteroids, Lex, have been around since the 1970s.
Yeah, the late 70s we started to use them more and more in Melbourne, and we were one of the first centres in the world that started to do that. And they really dramatically changed the outlook for some of these little babies, because a lot of them were born and they didn't really have too much problems with that surfactant deficiency, so they didn't really need too much support at all. So that really changed things quite dramatically. I think it's important to point out to people listening that these steroids are not the sort of steroids that the bodybuilders use or athletes might use to try and make themselves stronger. These are a different type of corticosteroid. They're anti-inflammatory, but in this instance what they do is they help the lungs to switch on earlier to make this surfactant. Normally babies will do it around 34 to 35 weeks of pregnancy. Normal pregnancy is up to 40 weeks, but if you're going to be born before then, giving the corticosteroids to the mothers will help switch on that production in the fetus, and so then when they're born they don't lack that surfactant.
So I think along with surfactant, antenatal corticosteroids are one of the big advances in neonatology in the last 40 years and really have saved a lot of lives. So for a few injections to mum before their baby's born, it really has a fantastic benefit.
Yes.
So here's a chest x-ray. Now again we've got a normal looking chest x-ray in the upper left hand corner, and then this is in the middle of the screen a chest x-ray of a preterm baby with RDS, and you can see the difference there, the lungs looking much whiter. And we also look to see how well expanded the lungs are, is there enough air getting in, and how much fluid is in the lungs as well.
So what the whiteness means to people listening is that there's not much air in the lung. That those airways have collapsed, air's gone, replaced by white, and so that's what we can see on the x-ray.
So lungs should look black because air looks dark on the chest x-ray.
Because they're basically full of air.
So we've talked a little. We've mentioned how we look after babies in the NICU a little bit, but here are some little babies, a very small baby on the right receiving what we call mechanical ventilation. So this is where we need to put a breathing tube down into the windpipe or the trachea, and babies are on a machine that helps them to breathe. And as Lex mentioned, mechanical ventilation has been around for 30 or 40 years, but when we first started ventilating babies back in the 70s, things were pretty crude.
Yes.
I'm pleased to say that we've come a long way with the way that we can mechanically ventilate babies now. We've got newer technologies, and the machines are much cleverer in the way that they particularly allow the baby to breathe for themselves. So if a baby wants to breathe, he or she can. If they need a bit more help, the machine can help out. So technology is advancing, but still we do know that we would rather avoid mechanical ventilation if we can. Even though we're much better at gentle ventilation, we still know that the longer babies are on a mechanical ventilator machine and the higher the pressures that they need to inflate their lungs, it can actually contribute to longer term lung disease. So we try very hard to avoid this. The one issue there is that to give surfactant, which many of our preterm babies need, the most common way to do that, and at the moment, is to give it down a breathing tube. So there's no avoiding putting a tube down into the windpipe for those babies who need surfactant, although we are looking very hard at ways that we might be able to do that more gently.
So Brett, the listeners might want to know that we started to use surfactant in 1991. We heard about it through the 80s, but we didn't have any in Australia. But in 1991 we could get it, and the first baby in Australia was treated in the Royal Women's Hospital in 1991, and that really changed that natural history, if you like, of the problem of RDS, because the trick was, before we had surfactant, to keep the baby alive long enough, because we knew after a few days they'd start to make it themselves, and then after another 4 or 5 days the original lack of surfactant would cure itself. But by giving it soon after birth, that shortened all of that quite dramatically. And so the x-rays you've shown of the really white lungs, we virtually never see it today, because the babies are born, if they need the surfactant they get it before the chest x-ray is done, and by the time the x-ray is done the lungs look nice and black. So we hardly ever see those white looking lungs anymore. It's completely different to what it was in the 70s and 80s.
And for many babies it's really amazing how quickly the surfactant works, isn't
Absolutely,
it? When
yes.
they're born and they need a lot of oxygen and a lot of help with their breathing, then the surfactant squirted down into their lungs, literally just squirted down,
Yep,
isn't it? And
that's right.
And immediately we see an effect where the need for oxygen comes right down, and the need for support comes right down.
This is in minutes. Yeah,
Within
right.
minutes.
Yeah.
Yeah. So one way that we can avoid mechanical ventilation is by using different types of breathing support, particularly into the nose. And for those of you who've had babies in the neonatal intensive care unit or special care nursery, you might recognise these forms of ventilation. On the left-hand side there we've got something called nasal high flow, and on the right-hand side we've got something called nasal CPAP. And these are what we call non-invasive forms of ventilation, that is that they're in the nose and they don't require a breathing tube to be inserted. And we now know from a lot of clinical studies that even the smallest babies can often be supported with these types of breathing with the aim to get away without using mechanical ventilation at all. But still we find in our smallest, sickest babies, we still need to give surfactant down a tube into the windpipe, and often with a period of mechanical ventilation. So what's the end point of all of this? Well, there's something called bronchopulmonary dysplasia, or BPD, and we like to just call that chronic lung disease of prematurity. And here's another chest x-ray. Again, this is in an older preterm infant that's been in the neonatal unit for some time. Again, what we're seeing in the lungs here is a lot of white instead of a lot of black. And what that's representing now, instead of what I showed previously, which was respiratory distress syndrome, this is now the scarring and inflammation associated with chronic lung disease of prematurity. And we know the smaller and earlier babies are born, the more troubles they have in the first weeks of life, the more likely they are to have this chronic lung disease. And for us, chronic lung disease is a diagnosis made at a point in time, which is when babies are 36 weeks post-menstrual age. And we use that as a marker or a surrogate for lung disease, how bad their lungs have disease has been and how likely they are to have problems in the future. It doesn't mean they will, and many babies recover after having chronic lung disease, but we still use it in all of our research studies as an important marker of what's going to happen later on.
So Brett, again, I think for people listening that probably about half of the little babies who are most immature, under 28 weeks, will end up with this problem at 36 weeks, but the other half won't. So question of whether the glass is half full or half empty. So as you say, we'll talk a bit more about the longer term outcomes of this condition in a minute.
And a big problem for us as the doctors and nurses looking after these patients is we can't predict which ones are going to get it.
No, that's right.
Sometimes we have a fair
idea. Not at birth
anyway. Not at birth.
As they're getting older, we can work out which way
Sometimes
they're
even in the little babies who do quite well in the first days and weeks of life, they can still end up with this problem.
That's right, yes.
So it's a real issue for us, and ideally we want to prevent BPD or chronic lung disease. And we know that some things work, but really there are very few therapies that are known to prevent or effectively treat BPD. We know that if we keep babies off the mechanical ventilator, that's a good thing, and using gentler forms of ventilation might help. There's also something that Lex has been heavily involved with, which is that any of you who've had babies in the neonatal unit will know that we treat many of them with caffeine, with coffee essentially. And there's been big studies showing that caffeine for little babies helps them to remember to breathe, keeps them their brain stimulated to breathe, but unexpectedly has long-term health benefits as well, and we might be able to talk more about that later. And we've mentioned antenatal steroids given to the mother before birth, but unfortunately they don't prevent chronic lung disease, but we can give similar forms of steroids to the babies themselves after they're born. And we know that that has both good effects, but also some side effects, and we have to be very careful about how we give those steroids. So a lot of our research is looking at how we new methods of preventing or treating BPD, such as new ways of giving steroids, other anti-inflammatory drugs that might be useful, and more recently stem cells have become a hot topic in our profession to see whether they can help repair the damage in the lungs or prevent it from happening in the first place. All right, so I've talked about what happens in the neonatal intensive care unit, and now I'm going to hand over to Lex, who's going to talk about issues after premature babies go home.
Thanks, Brett. So there are a number of things that I'm going to cover in this talk. Firstly, some of the babies go home on oxygen. There's the issue of being readmitted to hospital after you've gone home. Immunisations are important, a little bit about general health, and a little bit about long-term breathing ability. So these are the areas that I'll cover. So home oxygen. Some of you may have had your baby go home on oxygen, so you'll know all about it, but others won't know about this. Some babies do remain on oxygen for quite a long time, and they're otherwise ready to go home. In other words, they're big enough, they're feeding well enough, they're not doing anything else wrong. It's just that they're on a little bit of oxygen and it's keeping them in hospital. And so what happens is, for some of those babies, we need to show that if the oxygen was disconnected, they would be able to cope